So good evening, everyone, and welcome to this BAUS Innovations in Urology webinar. My name is Niamh Elliott, and I'm the Medical Manager with PAMEX Limited. So PAMEX Limited are the distributors of Utipro Plus in Ireland and now more recently in the UK. So this evening's webinar is going to focus on the management of recurrent UTIs with the particular emphasis on antibiotic stewardship and the role of antibiotic-free approaches in clinical practice. So I'm delighted to introduce our speaker this evening, Professor Tommaso. Tommaso is Professor of Urology at the Centre for Medical Sciences at the University of Trento in Italy. He is Head of Urology at Santa Chiara Regional Hospital and is a member of the EAU Guidelines Panel on Urological Infections. I'm also very pleased to introduce our chair, Ms. Jhumar Pati. So Ms. Pati is a consultant urological surgeon for 22 years at Homerton University Hospital and Barts Health. She began her consultant career at a time when female consultant urologists were still something of a novelty, although thankfully this has changed. And she specialises in a wide range of bladder conditions, including bladder cancer, ketamine cystitis, and recurrent UTIs. So thank you both to our speakers for joining this evening. And before I hand over to Professor Kai to start the presentation, we have a few short polling questions that I think are going to pop up on your screen now. So if you take just a couple of minutes to complete these, we'd really appreciate your input. So I think we have all the responses there. Again, thank you for completing. And I'm going to hand over to Professor Kai now to start his presentation.
So, good evening, ladies and gentlemen. I'll try to share my screen. Many thanks for the to the British Association of Urological Surgeons and to PAMEX, of course, for inviting me to speak about the non-antibiotic strategy for recurrent urinary tract infection, evidence, stewardship, and clinical practice. This is my disclosure statement, and this is my agenda for today. First of all, I would like to speak about the actual situation, and in particular, the unmet needs in a urinary tract infection, in particular recurrent urinary tract infection. Moreover, I would like to discuss with you the natural history of a recurrent urinary tract infection and present the current management landscape of recurrent cystitis. Moreover, I would like to spend some words about the antimicrobial stewardship in recurrent UTI, because this is very important to highlight that this is the time to change our approach to recurrent UTI. But moreover, I would like to highlight the role of Utipro Plus as non-antibiotic strategy for recurrent UTI, what should the guidelines say, and finally, I would like to discuss with you a brief clinical case. Starting from the actual situation and in the unmet need in recurrent cystitis, I have a question for you. My question is, why are we still talking about the management of a urinary tract infection more than 80 years after the discovery of penicillin by Sir Alexander Fleming? I think that in the 80s, we are very happy under the protection of antibiotics. But now, what's happened? The bacterial resistance destroyed our protection, destroyed the efficacy of antibiotics. And now, how we can overcome the problem? What we need to do in everyday clinical practice in order to overcome this problem? The fastest solution could be find a new umbrella. But as you will know, the number of new antibiotics in the company pipeline is decreasing in the last year, and now we have not new antibiotics to use in everyday clinical practice against cystitis and recurrent cystitis. What we need to do? The second solution, probably the best solution to do, is to change our point of view. Change our approach to recurrent UTI. As you all know, in a urinary tract infection, the use of antibiotics not always results in clinical efficacy, such as in this case, but it always results in a persistence of symptom or a recurrence. She is my young daughter. As you will know, the management of recurrent cystitis is often very complex. And the one of the most important thing to consider is that antibiotics are able to eradicate the infection, of course, but antibiotics are not able to prevent recurrence. Moreover, our guideline, the current literature suggest and highlight that both professional and patients are dissatisfied by the standard care in recurrent cystitis. And we have a lot of gray zone and unsatisfactory clinical results in the management of patients affected by recurrent urinary tract infection. Moreover, our guideline in the latest version, in the 2026 version, clearly highlight that recurrent cystitis negatively impacts patients' quality of life, leading to a reduction in quality of social and sexual relationship, reduction of self-esteem, and reduction of capacity to work. Moreover, few years ago, we clearly demonstrated that the number of symptomatic episodes in women affected by recurrent urinary tract infection, recurrent cystitis, is associated with an higher level of stress and anxiety. And this is very important to highlight. But how we can change our point of view, how we can change my approach to recurrent urinary tract infection. I believe that we need to come back to the bench. We need to come back to the analysis of natural history of recurrent UTI. In particular, we need to discuss about the pathophysiology as the rationale for the therapy. As you all know, the urinary bladder shows several mechanisms, several defense mechanisms. In particular, as you all know, a bladder has several layers of stratified urothelial cells that represent the first line of defense. Moreover, in the bladder and bladder cells, there are a lot of resident immune cells, such as mast cells, NK cells, or macrophages. In the case of bacteria in the urine, you can have two different clinical entities: a colonization, in other words, a symptomatic bacteriuria of the infection, urinary tract infection. But the present difference between these two clinical entities, asymptomatic bacteriuria and a urinary tract infection, is due to the type of bacteria, of course, and to the host response. This is very important to highlight also from a clinical point of view. Urinary tract infection, as you will know, is due to the presence of uropathogenic Escherichia coli colonizing the bladder mucosa, ascending from the perineum, from the bladder, through the urethra, through the vagina, and through the urethra. The presence of uropathogenic E. coli in the bladder lumen cause a production of antimicrobial peptide from the innate immune cells, and the presence of uropathogen E. coli stimulate through the presence of neutrophil and monocytes in the bladder length. Moreover, after the adhesion of E. coli to the bladder mucosa, bacteria were internalized in the vesicle, through the vesicle in the bladder epithelial cells, through the activation of toll-like receptor 1, toll-like receptor 4, and the increasing of AMPC cycle level, and E. coli were expelled into the lumen of the bladder. infection of the superficial epithelium can lead to a extensive exfoliation of the bladder epithelia, resulting in the loss of physical bacteria and causing the most common symptom of cystitis, that is hematuria. In association with the increasing of inflammation in deep urothelial cells, local mast cells, in particular local mast cells, start to increase the secretion of interleukin 10. The interleukin 10 is a specific cytokine that mediate the anti-inflammatory response in order to facilitate the regeneration of the epithelium. It is very important to highlight that the UTIs is the inflammation due to UTI is strictly limited to the bladder mucosa and no stimulate the production of antibody against the infecting bacteria. In fact, in the recurrent cystitis, we have no protective antibodies production in cystitis. This is very important to highlight because this is the reason of the recurrence. But what we need to remember, we need to remember that the important role of UPEC bacteria, uropathogenic E. coli, and the presence of intracellular and intracellular community in the bladder lining, this could be the reason for a recurrence and persistence of symptoms in women with a recurrent UTI. Moreover, we need to remember the role of gastrointestinal reservoir, and moreover, we need to consider the absence of production of antibodies against E. coli and other uropathogenic bacteria in women with recurrent cystitis. Moreover, it is very important to remember that antibiotics are able to eradicate the infection, but not to prevent the recurrence. Moving to the current management landscape of urinary tract infection, particularly recurrent cystitis, our guideline in the latest version clearly highlight that the prevention of recurrent cystitis includes several specific approach. First of all, risk factor assessment. The second one, the non-antimicrobial measure with the antibiotic-sparing approach, and the antimicrobial prophylaxis only in very selected patients. Our guideline highlight also that this approach should be attempted in this order. First of all, risk factor assessment, then the non-antimicrobial measure, and only in case of failure of this approach, you can use antimicrobial prophylaxis. This is very important to highlight because our guideline clearly highlight it. Our guideline also specified the specific risk factor age-related. In particular, our guideline suggested to consider in young and premenopausal women some risk factors such as sexual intercourse, use of spermicide, new sexual partner, and the history of cystitis during childhood. Moreover, in postmenopausal and elderly women, we have another type of risk factor that could be assessed and treated if possible, such as vaginitis, atrophic vaginitis due to estrogenic deficiency, or cystocyle, or increased post-volume urine, or the presence of catheter, and so and so. However, the importance of risk factors assessment and removal, if possible, of course, has been demonstrated in this our published paper. Here we enrolled a large cohort of women affected by recurrent cystitis. We perform a systematic and standardized identification of all risk factors related to recurrent UTI, of course, as intervention risk factor was treated or removal where possible, and patients with a no removal risk factor were included in the control group. All patients were scheduled to perform a follow-up visit every 6 months for 1 year. In this study, we clearly demonstrated that the risk factor assessment and removal is associated with a reduction of symptomatic recurrence, the reduction of and improvement of quality of life, of course, the reduction of stress and anxiety, and moreover, the assessment, the risk factor assessment and the early removal is associated with a reduction of antibiotic use in women affected by recurrent urinary tract infection, recurrent cystitis. The risk factors in our study has been performed, the risk factor assessment identification has been performed by using a validated nomogram. This is the validated Utipro nomogram, lower urinary tract infection recurrence nomogram. And this tool used clinical and laboratory parameters such as number of sexual partner, the bowel function, the pathogen, the presence of gram-positive or gram-negative, the hormonal status of the patients, the number of urinary tract infection, and most important, our nomogram consider the role of the previous asymptomatic bacteriuria treatment. For example, here you can see an example of the use of Utipro nomogram. If you have a woman with only one sexual partner with a normal bowel function, with a isolated E. coli and a gram-negative from the urine, fertility and hormonal status with a recurrent urinary tract infection, but with a previous treatment of asymptomatic bacteriuria, this woman account about 130 points, and 130 points is equal to have a 60% of probability to have a new symptomatic episode at 1 year after the evaluation. The Utipro nomogram is able to not only to perform a clear assessment evaluation of the risk to new symptomatic episode, but also the Utipro nomogram is able to stratify all patients into 3 groups. The first group is low risk, the second moderate, and the high risk. The 3 groups are considered should be considered in the management of a urinary tract infection, recurrent urinary tract infection, because in case of low risk patients, you can perform only the counseling about risk infection and suggest some modification about the lifestyle. In the moderate risk, you need to perform, of course, the counseling about risk factor, but you need to start with active prophylaxis in all motivated patients. In high risk patients, high risk woman, you need to perform a counseling and modification of lifestyle as in the previous 2 groups, but you need to start with active prophylaxis in all patients. Another aspect the role of risk factor assessment has been also highlighted in this recent paper published by the European Association of Urology guideline panel on urological infection. In this paper, we clearly highlighted that the first step for urologists is to reduce the patient's risk factor and promote behavior change. This is very important in all patients affected by recurrent urinary tract infection. Moreover, we highlight the importance of a correct diagnosis, of course, and accurate clinical assessment in order to reduce the risk of symptomatic recurrence. A few years ago, we published this systematic review and meta-analysis about the role of nutraceuticals and phytotherapy in the management of urinary tract infection, and we stated that a tailored approach according to the bacteria characteristic of host, but also according to patient's risk factor, profile is a very promising option to use in everyday clinical practice. So another thing to remember, to consider in everyday clinical practice, I would like to suggest to consider the fact that natural history of recurrent UTI is highly correlated with the risk factor and the early remover. Moreover, we need to use in everyday clinical practice a validated tools such as Lutire nomogram, for example, that is able to plan a personalized management in a woman with recurrent urinary tract infection, stick to the European Association of Urology guideline recommendation. But what about the antimicrobial stewardship? This is very important aspect to highlight in everyday clinical practice because the antibiotic resistance is one of the biggest public health challenges for the clinicians and for the for the health care system worldwide. We have a lot of die people due to the multi-drug resistant bacteria. Moreover, our guideline suggests to consider the antimicrobial stewardship as a pillar, is an important pillar of our activity. In fact, our guideline highlights that in our care hospitals, from 20 to 50% of prescribed antibiotics are inappropriate or unnecessary. And this is a very important aspect to highlight. Moreover, we need that the urinary tract infection are the most common reason for antibiotic prescription globally. And in the last years, we saw an high rising of prevalence of ESBL producing coli and carbapenem resistance enterobacteriaceae also in women affected by recurrent urinary tract infection. But what about antimicrobial stewardship in everyday clinical practice? What does it mean, antimicrobial stewardship? It is very important to be sure about the right dose, the right drug, the right antibiotic, of course, the right dose, the right duration of the therapy, and in particular, the right patients. We need to perform an accurate diagnosis of urinary tract infection, but it is very important to perform an accurate management. The management, I would like to stress the management of asymptomatic bacteriuria. As we stated before, the presence of bacteria can cause asymptomatic bacteriuria or infection. I would like to stress the role of asymptomatic bacteriuria management in women with recurrent urinary tract infection. Several years ago, we demonstrated that the treatment of asymptomatic bacteriuria in women affected by recurrent urinary tract infection, recurrent cystitis, is associated with a high risk of new symptomatic episode and a decreasing on quality of life. Moreover, in other study, we demonstrated that asymptomatic bacterial treatment in women with recurrent cystitis is associated with a higher prevalence of antibiotic-resistant strains in women with urinary tract infection. Our guidelines, such as the most common and the other international guideline, suggest to screen and treat asymptomatic bacteriuria only in case of pregnant woman and only in case of patient before to urological surgery, but only in case of urological procedure entering urinary tract and breaching the mucosa. A correct approach to patients with asymptomatic bacteriuria, both in urological and non-urological field, is another step forward in achieve the principle of asymptomatic antimicrobial stewardship. But what we need to remember that one of the most frequent cause of antibiotic prescription worldwide is urinary tract infection, both in outpatients and in inpatients. Moreover, the antibiotics in urinary tract infection are a cause of antimicrobial resistance, and I suggest to check the guideline in order to screen and treat asymptomatic bacteriuria if needed. Moreover, we need to consider an antimicrobial sparing approach as a first part of our approach to patients affected by recurrent UTI. Moving to the core of my presentation, the Utipro Plus and the non-antibiotic strategy, I would like to start considering that in the last year, the scientific interest in antibiotic antimicrobial sparing approach is increasing, especially in the last year. For this reason, our guideline in the version 2024 include a paragraph, a specific section about the role of nutraceutical and phytotherapy in the management of urinary tract infection. But what are the evidence about the recommendation from a EU guideline? Starting from the probiotics, what about probiotics? The current evidence is insufficient, and we have too low quality study to provide specific recommendation on the administration road, optimal dosage, and the duration of probiotics prophylaxis. For this reason, the use of probiotics in the management of recurrent urinary tract infection is not approved by our guideline. The same situation in case of cranberry. We have a low quality data, and recently the systematic review indicated that cranberry juice combined with increased fluid intake may reduce cystitis rates and antibiotic use. In other words, the cranberry use is associated with a decreasing risk of recurrent UTI only when associated with an increased fluid intake. So for this reason, our guideline do not approve the use of cranberry in the management of recurrent urinary tract infection. What about dimanose? Dimanose is frequently used in everyday clinical practice, but a recent systematic review and meta-analysis indicated that dimanose may be protective against recurrent cystitis when compared with placebo. Nevertheless, this finding must be interpreted with a lot of attention due to the small number of study, variation in study design and quality issue, and overall limited sample size. Recently, a double-blind randomized controlled trial demonstrated that the daily dose of dimanose did not reduce the proportion of women with recurrent cystitis. And for this reason, neither dimanose has been approved by our guideline. Moving to the xyloglucan hibiscus propolis, a specific combination named Utipro Plus, our guideline evaluated a lot of preclinical and clinical trial. In particular, our guideline highlight that xyloglucan is able to create a barrier that prevent the uropathogenic E. coli adhesion to the bowel cells and to the urothelial cells. Moreover, a recent systematic review demonstrated that a combination of xyloglucan, hibiscus, and propolis is effective in preventing recurrent cystitis compared to the placebo, showing also a nice patient compliance and, more important, reduction in antibiotic use. For this reason, our guideline approve the use of xyloglucan, hibiscus, and propolis for the treatment and for the management of recurrent urinary tract infection. But looking to the EU guideline and the level of evidence, if you can see in this table about the summary of evidence and recommendation for non-antibiotic management of cystitis, you can see that our guideline recommend to use a combination of xyloglucan, hibiscus, and propolis in relief acute symptom of cystitis and in preventing recurrence with a very high level of evidence. But moving to the source of recommendation from our guideline, what we can find in the current literature, we can find that a combination, Utipro Plus combination of xyloglucan, hibiscus, and propolis is able to create a barrier at the bowel function and urothelia and the bowel site and urothelian bladder site in order to decrease the adhesion of E. coli and in order to decrease the inflammation due to the E. coli adherence and internalization in the urothelial sense, and this study, this preclinical study, showed that xyloglucan is a promising non-pharmacologic barrier to use in order to reduce the recurrence in women with recurrent urinary tract infection. Moreover, few years ago, we performed a longitudinal study in which we demonstrated in women with a recurrent urinary tract infection in a cohort of 61 women affected by recurrent cystitis that this medical device is able to improve the quality of life and reduce recurrence, reduce symptomatic episode, and in particular, reduce the use of antibiotic in a woman with recurrent cystitis. Another study, another retrospective study about the use of Utipro Plus in everyday clinical practice that I would like to show you. This is a retrospective cross-sectional study based on a specific database, the IQVA database that include information provided by office-based physicians, GP, urologist, and gynecologist in Germany. In this study, more than 3,500 patients has been included. This study evaluated the impact of Utipro Plus in women in the management of recurrent UTI. In particular, all women were treated by GP, gynecologist, or urologist with the prescription of Utipro Plus in the specific period, and we evaluate three important outcomes for evaluate the impact of Utipro Plus in women with recurrent UTI. First of all, we evaluated the number of recurrent cystitis within the 100 after the prescription of Utipro Plus compared to the 1 year before the prescription. Moreover, we evaluated the number of antibiotic prescription in the study period compared with the 1 year before, and moreover, we evaluated the number of days of sick leave in the same population. What we find very interesting results. We found that Utipro Plus is able to reduce the number of symptomatic episodes in the study period comparing with the years before. Moreover, the Utipro Plus is able to reduce significantly the use of antibiotics and antibiotic prescription, of course, and moreover, the Utipro Plus is able to decrease the day of sick leave in women with recurrent urinary tract infection. A few years ago, we performed a systematic review and meta-analysis comparing the efficacy of Utipro Plus, a combination of xyloglucan, hibiscus, and propolis in the management of uncomplicated urinary tract infection. And we found in comparing Utipro Plus with the other competitor that Utipro Plus is superior to other competitor regimen in terms of clinical cure and in terms of safety profile. The efficacy of Utipro Plus is due to a specific mechanism. First of all, Utipro Plus is able to restoration of mucosal barrier, inhibition of E. coli adhesion to the epithelium, and modulation of inflammation, both at urothelial and intestinal level, restoring also the health gut lining and decrease the level of inflammation also at intestinal level. In other words, Utipro Plus is able to act at the intestinal level and at the bladder level, decrease the symptoms acting at the bladder level, and decrease the risk of E. coli transmigration and adhesion to the bowel acting at the intestinal level. So comparing the efficacy of Utipro Plus with the other antimicrobial sparing compound, we found that Utipro Plus is superior to cranberry or the other non-antibiotic approach in terms of UTI incidence, day of sick leave, and antibiotic use. This is data come from the analysis of literature. For this reason, our guideline recommend to use Utipro Plus in the prevention of recurrent urinary tract infection. For concluding, I would like to show you a very brief clinical case in order to discuss with you some specific aspect about the management of patients affected by recurrent cystitis. This is my clinical case. Maria is a young woman affected by recurrent urinary tract infection. She has more than 6 episodes in the last 1 year, and she has filed multiple short course of empirical antibiotic treatment, nitrofurantoin, fosfomycin, and also ciprofloxacin because she suspected a pyelonephritis. From the quality of life of Maria, she reports a significant impact in quality of life, and she is terrified of antimicrobial resistance and new recurrence. She come to our attention at another symptomatic episode. She present a E. coli isolation from the urine, sensitivity to nitrofurantoin and other antibiotic, but resistant to fluoroquinolone. We have no abnormality at imaging assessment, and evaluating she has also a very impact in quality of life, demonstrated also by the administration of questionnaire, and evaluating the risk factor. She has a postcoital avoiding not routinely practiced. She present a poor liquid intake, less than 1 liter per day. She has also constipation, and moreover, she delayed voiding due to a demanding office job. Considering the lutein nomogram, she has this point, only one partner, constipation, E. coli isolation from the urine. She is fertile, of course. She's a young woman affected by recurrent UTI. She has treated asymptomatic bacteriuria before, and she account about 180 point in lutein nomogram. It is equal to 75% of probability to have a new episode in the 1 year. According to the lutein nomogram, Maria is considered at high risk to develop a new episode, and in all patients with a high risk, we need to perform evaluation of risk factors, full course counseling, active counseling about lifestyle modification, and in particular, in this case of patients, we need to start with an active prophylaxis in all patients. Follow-up, of course, is required. We decided to treat the acute symptomatic episode by using a short course of antibiotic with a narrow spectrum antibiotic, fosfomycin, trometamol, only 1 sachet per day for only 1 day, and we decided to start with a non-antibiotic approach as our guideline suggests. We start with Utipro Plus with this schedule, 1 capsule a day for 15 days, 1 cycle every month for 6 months. I prefer to use not only a attack schedule, but I prefer to use a cycle treatment in order to improve the efficacy of xyloglucane biscuits properly, in order to increase Utipro Plus efficacy, and in order to decrease the risk of new episode. But what's happened at the follow-up? At the follow-up, she is very happy because the patients reported the height adherence to behavior change, and she have no adverse effects reported by the therapy, and she reported an high adherence to the therapy. She reported only one episode of acute urinary tract infection treated with nitrofurantoin in accordance with our guideline with clinical success, and she reported a transition to asymptomatic bacteriuria. I would like to stress this aspect because if you have a patient that show a transition from a UTI to asymptomatic bacteriuria, you need to consider it such a success of the therapy. This is very important because, as we demonstrated, the asymptomatic bacteriuria could have a protective role against the presence of more dangerous bacteria. But the most important aspect that I would like to report to you, that the patient's satisfaction. She said that I finally have my life back without needing antibiotics. This is very important to highlight. So, moving to the conclusion and looking to the future, I think that we have a lot of work to do in the field of urinary tract infection, in particular in the management of patients affected by recurrent cystitis. I think that we need to work a lot because the awareness about antibiotic-sparing approach is still low among general practitioners, urologists, gynecologists, and probably ED physicians. I need however, I think that the guideline provide a clear direction on our clinical action, and the guideline are explicit regarding our responsibility. Our guideline clearly demonstrated a simple flow chart for the management of patients affected by recurrent urinary tract infection, in particular recurrent cystitis. The guidelines say to start with risk factor assessment and counseling modification, lifestyle modification, then start with a non-antibiotic approach and with an antibiotic sparing approach, and only in case of failure, we need to consider the antibiotic prophylaxis, but only in very selected patients. I think that this is the time to change our point of view. This is the time of change our management of urinary tract infection. Particularly, we need to change our approach to patients affected by recurrent urinary tract infection, and we also to start to collaborate with all physicians managing urinary tract infection. In particular, we need also to collaborate with the gynecologist, general practitioner, infectious disease, and microbiologist in order to evaluate also the local resistance in our country. Finally, I would like to stress the fact that the antimicrobial sparing approach on urinary tract infection is able to make the difference in the management of women affected by recurrent cystitis. Thank you very much for your attention.
Professor Guy, thank you so much. That was an excellent presentation and an excellent insight into the pathophysiology of UTIs. I have some questions from the Q&A, which we summarized into a few sections. The first one is, does repeated urine cultures and sensitivities help in managing recurrent UTIs? And
yes.
Do you recommend doing any extra sensitivities for any atypical bacteria, for example?
Yeah, thank you. Many thanks, Pati, for this important question. So this question gives me the possibility to highlight some specific aspects about the management of cystitis. First of all, in the acute sporadic cystitis, we need not to perform a urinary culture infection, and we need to start with empirical treatment according to the guideline. Okay, this is the sporadic cystitis. But in a recurrent urinary tract infection, we need to perform urinary culture before prescribe antibiotic prescription in order to evaluate the type of bacteria, the isolated bacteria, and in order to evaluate the sensibility profile, in order also to treat with antibiotic if needed the future symptomatic episode. But in recurrent UTI, also our guidelines suggest to perform urinary culture.
Do you think that there's a role for long-term prophylaxis for people? Or, I mean, when we did our poll, the vast majority of people thought that 3 months was adequate for prophylaxis.
Yeah. The role of long-term antibiotic prophylaxis is very controversial because our guidelines suggested to use antibiotic prophylaxis only in case of failure of lifestyle change, lifestyle modification, and antibiotic-sparing approach. If you have a patient with that failure to the lifestyle change and to non-antimicrobial prophylaxis, you can start with antibiotic prophylaxis. Generally, I use fosfomycin trometamol as indicated by our guideline, 1 sachet per day every 10 days for at least 6 months. You can also use a low dose of nitrofurantoin in selected patients, but pay attention to the other comorbidity and other concomitant therapy, because the long-term use of nitrofurantoin is contraindicated in specific type of patients. However, I think that we can start, if you need to start with antibiotic prophylaxis, you can prolong the treatment at least for 6 months.
And do you have an approach, for example, when I'm seeing patients in my clinic similar to Maria? I sometimes step down, so I would give them an antibiotic prophylaxis nightly for a certain number of months, and then step down to precoital, and then step down to only when they become slightly symptomatic, as if a UTI was about to occur, then they take prophylaxis. Do you have any comments on it?
Yeah. Very interesting comment, and this comment giving me the possibility to highlight the culture of the culture of the urinary culture, because I suggested to perform to all of my patients to perform urinary culture only in case of symptoms, and not to perform urinary culture after a course of antibiotics if you haven't any symptoms. This is very important, because sometimes, as we discussed before, after antibiotic treatment, you can find asymptomatic bacteriuria in woman, in asymptomatic woman, and the risk is to treat asymptomatic bacteriuria. Treat asymptomatic bacteriuria is obviously associated with a high risk of recurrence and a high risk of multi-drug resistant bacteria. Yeah, of course.
Yeah, absolutely agree with you on that. There are quite a few questions in the Q&A about the type of pathogens that the UTI Pro Plus may work against. Does it only work for E. coli or other organisms as well?
Yeah. Very interesting question. Very interesting question. Because of course, E. coli is the most common isolated pathogen in women with a urinary tract infection, in particular in a woman with cystitis. Of course, but in the last years, we isolated a different population of bacteria. First, for example, we saw an increasing of gram-positive bacteria in women with recurrent urinary tract infection, in particular Enterococcus faecium and Enterococcus fecalis. Moreover, we in some cases we also isolated Klebsiella and Proteus, and in several cases these atypical bacteria are very resistant to the most common antibiotics. In sporadic UTI, generally we isolated E. coli, but in women with recurrent UTI and in women that who use a lot of antibiotic, especially in women with change every time antibiotics, we found a high prevalence of resistant bacteria. I can't hear you. I can't hear you. You are mute.
So, sorry, you don't approve of cycling the antibiotics then, because that would promote resistance. Is that correct?
Yeah, okay, correct. Yeah. The antimicrobial resistance is absolutely related to the cycle of antibiotic.
So there are quite a number of questions on UTIPro Plus. First of all, as far as I know, you don't need a prescription for it. That was one of the questions. You can actually just get it directly from the PAMEX website, or I think it's shortly going to be available in Boots. Neve is going to talk about that later, I think. Do you want to tell us? Yeah. Is it going to be available in Boots?
Yeah. Please.
You're on, Neve.
Oh, I'm on, great, sorry. Yeah, so currently it is available to purchase online via the Boots website, also Lloyd's Pharmacy, Pharmacy to You, and as you mentioned, Miss Patti, through the utipro.co.uk website, and also via Amazon.
Excellent. Can you tell us, Professor, why you think the 15-day cycle is important to stop and then start again for the 6-month duration that you've recommended?
I recommend it, as I describe it in my clinical case. I recommend that to start with an attacked dose, 15 days, of course, and then I perform a continuous cycle of Utipro Plus treatment, because I think that we need to create a sort of restoration of the whole intestinal mucosa, and we need also to continue to perform a restoration of urothelium and decrease the level of inflammation both at the intestinal side and urothelial side. I think that the cycle, the 6-month period is important also in order to give the possibility to the woman to change their lifestyle and to change to remove a risk factor, because it is very easy to cancel a woman about the risk factor, but because it's very difficult for the woman to adherent to our recommendation about the lifestyle, of course.
And have you ever recommended UTIPro for men?
In men?
Yeah.
Yeah. Unfortunately, we have a lot of men with recurrent UTI, in particular recurrent bacterial prostatitis, of course, but the prevalence of recurrent prostatitis is very low. Fortunately, is very low, and probably this kind of product, the antibiotic sparing approach, could have also a role in the prophylaxis and the prevention of recurrent bacterial prostatitis.
That's really interesting. I think quite a lot of patients may benefit from that if that is useful. I haven't used that in my practice, but certainly something to think about. There's a question from Trevor Dawkins about whether you've ever used a combination of Utipro Plus and methanamine. Do you think it's worthwhile? Because they have a similar mode of action.
Yeah. This is very important aspect because we need to consider the approach to recurrent UTI as a multimodal approach. We can start with Utipro Plus, of course, in association with, for example, endovesical instillation with hyaluronic acid, for example, or in association with immunotherapy and vaccine, because several times the physiopathology of a recurrent UTI is due to the multiple causes. And in a selected case, in a woman that failure a lot of treatment, we can start with a multimodal approach. Utipro Plus, of course, that is able to act at the intestinal level, and for example, to associate an bladder installation with hyaluronic acid that is able to create the glycosamine glycan layer and reduce the symptom. However, it is very important comment, very important.
Thank you. There are a few more questions about multi-drug resistant UTIs. Do you have any particular strategy for those?
In order to prevent the development of, or in order to treat?
When it's already happened, to treat them?
First of all, we need to be sure that this is a cystitis, because several times we have a lot of women that attend our center with a multi-drug resistant E. coli or isolated from the urine, but she doesn't have symptoms related to cystitis. Several times she has a vaginitis or other non-urological disease. The first most important is perform a correct diagnosis in order to be sure about our approach. And in a case of multi-drug resistant, in especially Klebsiella or E. coli, we need to discuss about the case with our microbiologist in order to check the sensibility of antibiotic, and with our infectious disease consultant, because before prescribe antibiotic. However, in a woman with a multi-drug resistant bacteria, the recommendation is start immediately with a non-antibiotic sparing approach if she hasn't systemic symptoms, of course.
Sure, of course. Now, in the UK, I mean, Hiprex is NICE approved, and I'm not sure if Utipro Plus has been NICE approved yet. What would you say to people who want to use one or the other?
Excuse me, can you repeat
so
again?
I'm saying in the UK, NICE, Institute of Clinical Experts, has approved Hiprex as something that we ought to try in patients with recurrent UTIs, and seems to have reasonably good results. So my strategy is I usually start patients on antibiotic prophylaxis and Hiprex, and then remove the antibiotic prophylaxis as soon as possible, just to help their symptoms calm down immediately, and regain their trust in treatment, basically.
Yeah.
Would you recommend the dual approach?
Yeah, it's interesting. It's a very interesting approach. However, I would like also to highlight that in several cases you can also in case of acute cystitis, you can also anti-inflammatory drugs, such as ibuprofen, for example. Several years ago has been published a paper comparing the fosfomycin trometamol against ibuprofen treatment. And the author stated that no difference between the two groups in terms of pyelonephritis and in terms of clinical response. However, I find that this approach very, very interesting. Our guideline did not consider metamine Iprex for the treatment of the recurrent urinary tract infection. It could be very interesting to create a sort of international consortium in order to create international guideline for the management of a recurrent urinary tract infection.
Okay, there's quite a few mentions of the ALTA trial with methanamine versus an antibiotic prophylaxis in the chat, and similar efficacy for both. So I know that a number of people have mentioned this trial. Now, someone's just asking, is UTI Pro Plus available in Iraq?
No, I have a very few experience with metamine epurate in both in acute and recurrent field. But of course, I think that the message is avoid the use of antibiotic and prefer the use of non-antibiotic sparing approach, such as metamine epurate, of course. But I would like to highlight a specific aspect. The metamine epurate is able to act only at the bladder level, and this is demonstrated. Other non-antimicrobial prophylaxis, such as Utipro Plus, for example, is able to act at the source of the infection, because it's able to increase the barrier, the intestinal barrier, to decrease the adhesion of E. coli, and the most important aspect is able to decrease the inflammation related to the adhesion of E. coli to the intestinal mucosa or to the urothelium. This is very, very important to highlight and to specify these two different mechanisms of action.
Thank you, Professor. I think we're just running out of time now. It's 20:03. So great thanks to the wonderful audience and for the great questions that they've sent earlier and also again today. Thank you also very much to Professor for answering all the questions very succinctly. I'm going to hand you all back to Neve now. So Neve, take it away.
Thank you, Ms. Patti, and thank you to you and Professor Kai for a very insightful presentation and discussion, and thank you for everyone for attending tonight, and also to the organisers and BAUS. We would really appreciate your feedback via the post-webinar questions, and to finish we have a short video which we're going to play. So thank you again and hope everyone has a lovely evening.
Thank you.